Or do I get to advance my slides? Awesome. All right, so our objectives for this very brief 10 to 15-minute talk is for me to tell you just a little bit about the prevalence of cognitive impairment and the most common types of cognitive impairment that you would see in your heart failure patients, and to give you some justification of why you should take some time out of your very busy clinical schedule to do screening, and give you resources to some screens that I feel have the most evidence and are most reasonable to implement in clinical settings. So what is cognition? Cognition is not just memory. You know, cognition includes multiple domains, including attention, executive function, psychomotor speed, language, and speech. So when we talk about cognitive impairment, we're not talking just about forgetfulness. We're talking about deficits in those multiple domains, and the deficits that affect a person's ability to use language appropriately, to perceive information, and to learn and to remember specific knowledge. There are two different major categories of cognitive impairment in heart failure, and one is acute and fluctuating or delirium. This type of cognitive impairment is most prevalent in decompensated heart failure. And another subtype is chronic. Usually, the types of chronic cognitive impairment have more of an insidious onset and slower progression. And chronic types include subjective cognitive decline, mild cognitive impairment, and dementia. Again, they're very broad categories. They're more prevalent in patients with stable heart failure, and usually they worsen over time. Now, subjective cognitive impairment is a fairly new category. We just started talking about subjective cognitive impairment as a clinical kind of unit of analysis maybe 5-6 years ago. Before, when patients would come in and tell you, I'm really worried about my memory, but they seem to do very well on cognitive tests, and their spouse, so whomever the informant comes with them, say, I don't notice anything, he's just anxious. We would kind of dismiss the patients. Right now, there's been several large studies that shows that those worried well are not so well, that they have higher prevalence of dementia type of pathology, and they have higher conversion rate to mild cognitive impairment, and some eventually to dementia. So we want to be aware of that and not dismiss anybody's concerns of worsening cognitive impairment. So overall prevalence of cognitive impairment is very broad depending on the population studied. So ranging from 25 to 80%. And if we're looking at older adults with multiple comorbidities, we're looking at about 80% prevalence of quite significant cognitive impairment. If we're looking at healthier younger adults, cognitive impairment prevalence is not as high. Mild cognitive impairment is one of the most common types of impairment that we see in heart failure patients. And again, because I have very short time with you, I can go through diagnostics, but the bottom line, mild cognitive impairment is when a person is concerned about their function, when in cognitive screening we're noticing that something is wrong, they don't perform as well as norms in the population would be, but day-to-day function is not affected. Maybe patient is very forgetful, but they make themselves reminders. Their phone tells them what to do and when. You know, they have systems in place where they do what they need to do to get through the day well. But we're noticing some slight decline in cognition on cognitive testing. That's how we differentiate mild cognitive impairment from dementia and subjective cognitive decline. As most of you have appropriately answered, there are multiple processes, physiological processes that contribute to manifestations of cognitive impairment in heart failure. So cerebral hyperperfusion is associated with gray matter loss. The risk factors for cerebral hyperperfusion are actually low systolic blood pressure and obesity. So we have to be careful, especially when we are medicating hypertension in older adults, that we don't over-medicate, because we know that this could actually be contributing to some cognitive impairment if they're consistently having very low blood pressure and corresponding cerebral hyperperfusion. Arterial hypertension, production of pro-inflammatory cytokines, and depressed mood. Again, you know, you had a talk on depression, I think, just last month, and depression is very, very prevalent in heart failure. For all the patients, we even have a term we call pseudodementia, and it is when a patient, usually an older adult, has such a severe, profound depression that they present with cognitive impairment. But again, the prevalence is low for pseudodementias, but those patients actually respond to treatment and cognition improves significantly, if not back to baseline. So it's important to be aware. If cognitive impairment is caused by structural neurodegenerative changes, we really can't reverse it. There could be a point in time where there's just enough gray matter loss, where there's enough issues where cognitive impairment is irreversible. But if it's caused by functional neuronal dysfunction, then it can be improved or maybe even reversed with successful medication management, with pacemakers, with transplants, with lifestyle modification. And we have evidence that appropriate antihypertensive treatment in combination with exercise program actually helps is protective for developing cognitive impairment and is helpful in improving the symptoms of cognitive impairment in stable heart failure patients. I want to touch on patterns of decline that you may see. Language usually has linear decline. It kind of gradually gets worse, worse, and worse unless appropriate interventions are in place and the person is responsive to interventions. Attention and executive function and psychomotor function tend to fluctuate in heart failure patients. So they may present to you on a good day, and you may not notice difficulty with attention and executive function, but then at home, the caregiver would say, the patient is not performing as well. And visual spatial skills and memory may recover over time, again, if heart failure is well controlled. It's important to screen. Why is it important to screen? Because we have very robust data that shows that patients with heart failure who have significant cognitive impairment, usually mild cognitive impairment or dementia, have much worse overall outcomes. They're not capable of really adhering to a complex heart failure management regimens that they need to adhere to at home, and they're really not able to follow through with the treatment. So if we miss cognitive impairment that's significant in these patients, and if we don't engage their loved ones in helping them manage their heart failure, regardless of how well our care plan is, our patients may not stabilize and may not really maintain very good function. So it's really, really important. A word of caution, cognitive screens are not diagnostic at all whatsoever. It's just something that raises your degree of suspicion. To really diagnose somebody with mild cognitive impairment or dementia, it requires history examination, laboratory test, and much more comprehensive evaluation. So when to screen? My recommendation, considering high prevalence of cognitive impairment and heart failure, especially if you're working with older adults, that you screen at least annually. And then you screen more frequently when somebody is expressing concerns about their memory. Again, because you're a specialist in a very busy specialty practice, I recommend that if you have suspicion that somebody has cognitive impairment, if they screen positive, you have conversation right there, right then with their caregiver, if they're fortunate enough to have one at a point of care, caregiver and a patient, to say, I have some concerns about your memory. Your memory may or may not impede your ability to manage medication regimen at home. I would really like to refer you back to your primary care provider, to some other community resources. If somebody has frank dementia, you can tell, you really should be referring them to memory disorders clinic for an evaluation. But if somebody just slightly forgetful and screen positive on a cognitive screen, have a conversation with the patient, have a conversation with their caregiver, refer them out, and always refer them to community resources. Alzheimer's Association has a 24/7 hotline that's staffed by social workers and nurses that are well equipped to answer all kind of early questions and to help people find resources in their area. This slide is for your information. I'm listing kind of most of the screens that are routinely used in different clinical practices, and I'm not going to take your time reviewing them all. I'll tell you about two of my favorite and the ones that I strongly endorse, and I'll tell you why they stand out. So I'm impartial to MiniCog. This 3-minute screen was developed by my long-term mentor and collaborator here at the University of Washington, Dr. Sue Borson. She is a former director of our memory disorders clinic, and it's really fantastic screen to use at the point of care. It takes about 3 minutes. You ask the patient to listen to you, give them 3 words. For example, apple, table, penny. Please repeat the words for me.
Apple, table, penny.
Excellent. Could you please hold on to these words in your memory? And I'm going to give you this big piece of paper with a circle in it. Could you please put the numbers the way they would go in the face of the clock? He put the numbers. And now could you please set the time to be 10 minutes past 11? Excellent. And he drew this beautiful clock. It's totally appropriate. What were the 3 words that we learned earlier?
Apple, table, penny.
Excellent. So this particular patient, I would not be terribly concerned about cognitive impairment. Now the trap is mini-cog was not designed to catch mild cognitive impairment. It's really designed for frank dementia. So somebody has to have significant impairment for us to identify it in a mini-cog. It's a wonderful screen. It has 99% sensitivity for dementia. So if my patient had dementia, I would most likely be alerted by his inability to perform the simple test. But if he had mild cognitive impairment that can still interfere with his ability to manage his heart failure regimen, and mini-cog may not catch it. So the other screen that I think is probably has best evidence is Montreal Cognitive Assessment Scale, or MoCA. It has a really wonderful short version that takes probably about 8 to 7 minutes to administer. It's 90% sensitive to mild cognitive impairment. But this is something that I don't envision you being able to do in your busy specialty clinic, because you may not have 10 to 15 minutes to administer and to interpret the test. So if you have nursing staff of a medical assistant that could be trained in administering MoCA, that would be really wonderful to utilize the resources of the clinic to invest in doing, because I think you can greatly improve your patient's outcomes by catching mild cognitive impairment. Because a lot of your patients may not want to go to primary care or any other specialist. They may only come to you because they have to save their lives, and you could be the only eyes and ears for this patient. I think it's also very, very important not to just administer cognitive screen to a patient, but administer it to a family member if they happen to have an informant with them. And the one I like very much is 88. Very, very simple scale. We have a link to resources for you to access it. By the way, mini-cog, MoCA, and 88 are all free of charge. Simple list of 8 questions that's asking an informant if they observed any signs of cognitive impairment. It's 80% sensitive in dementia, again, not as sensitive to mild cognitive impairment, but it's very informative. So while you're performing a physical exam with the patient, you can just hand a piece of paper to a caregiver and say, could you please fill this out for me? And that would give you a lot of information. And here's how you access those